বঙ্গবন্ধু স্বদেশ প্রত্যাবর্তন দিবস। 1972-এর এই দিনে বঙ্গবন্ধু দেশে ফিরে এসেছিলেন, পূর্ণতা পেয়েছিল আমাদের স্বাধীনতা, এবং আমরা একটা নতুন যাত্রা শুরু করেছিলাম। প্ল্যানেটারি হেলথ একাডেমিয়া হচ্ছে প্রবাসী বাংলাদেশি চিকিৎসকদের একটি প্ল্যাটফর্ম। মার্কিন যুক্তরাষ্ট্র, যুক্তরাজ্য, ইউরোপ এবং অস্ট্রেলিয়ায় বসবাসরত বিশেষজ্ঞ বাঙালি চিকিৎসকরা তাদের মাতৃভূমির প্রতি তাগিদ থেকে সংগঠনটি গড়ে তুলেছেন, যাতে তাদের এক্সপার্টিস থেকে বাংলাদেশ উপকৃত হয়। সেই ধারাবাহিকতায় আজকের এই ওয়েবিনারটি। আমরা এই ওয়েবিনারটি করার জন্য আজকের দিনটি এই কারণে বেছে নিয়েছি যে আমরা মনে করি যে আমরা যারা দেশে বিশেষজ্ঞ চিকিৎসা সেবা প্রদান করছি এবং তারা যারা বিদেশে আছেন, তাদের মধ্যে এই যে যোগসূত্র, সেটি আমাদের বাংলাদেশের স্বাস্থ্য খাতকে এগিয়ে নেওয়ার ক্ষেত্রে গুরুত্বপূর্ণ ভূমিকা রাখবে। আজকে আমরা বেছে নিয়েছি অটোইমিউন লিভার ডিজিজকে আজকে আলোচনার বিষয়বস্তু হিসেবে। আমি আমার সহকর্মী বঙ্গবন্ধু শেখ মুজিব মেডিকেল অ্যাসোসিয়েশন বঙ্গবন্ধু শেখ মুজিব মেডিকেল বিশ্ববিদ্যালয় হেপাটোলজি অ্যালুমনাই অ্যাসোসিয়েশনের জেনারেল সেক্রেটারি, নোয়াখালীর আব্দুল মালেক মেডিকেল কলেজের লিভার বিভাগের প্রধান সহযোগী অধ্যাপক ডক্টর আব্দুর রহিমকে এখন অনুরোধ জানাবো অনুষ্ঠানের পরবর্তী অংশটি সঞ্চালনের জন্য। ধন্যবাদ রহিম ভাই।
শোনা যায়?
জি, শোনা যাচ্ছে।
Good evening, Assalamu alaikum. I am Dr. Abdur Rahim. Welcome to you all to this webinar on autoimmune liver disease. The speaker of this disease are Dr. Atiquzzaman and Dr. Ashraf Malek. Dr. Atiquzzaman, consultant, gastroenterology and hepatology, University of Central Florida, USA, and Dr. Ashraf Malek, Associate Medical Director, Transplant Hepatologist, New Jersey, USA. And the panelists are Dr. Ezazul Haq, Vice Principal, Kumila Medical College, Dr. Alok Kumar Raha, Associate Professor and Department of Head, Chirang Medical College, Dr. Arun Jyoti Tarabdar, Associate Professor, Mamun Medical College, and also Prabhat Kumar Poddar, Associate Professor, Hepatology Department, Salimullah Medical College. I welcome to all the participants and panelists, and this webinar is organized by Forum for the Study of the Liver Bangladesh and Hepatology Alumni Association and is sponsored by Beacon Pharmaceuticals. Now I invite Dr. Atiquzzaman, consultant gastroenterology and hepatology, University of Central Florida, to deliver his speech. Dr. Atiquzzaman. Hello.
Please unmute yourself.
First of all, I'd like to thank Shwapnil, Professor Mahtab, Mamun Mahtab, to coordinate this wonderful webinar. I would like to thank all the esteemed faculty. Some of them are my beloved younger brothers from Bangladesh. All of you are. And I'm also very happy that Dr. Ashraf, a transplant hepatologist, joined us. We have this platform called Planetary Health Alliance, and we try to collaborate and coordinate. And Professor Mahtab, the way he said that this is the time to give back. And what can be the best day to start it? Today is Bangabandhuর স্বদেশ প্রত্যাবর্তন দিবস। আমাদের বঙ্গবন্ধু যেদিন ফিরে এসেছিলেন এই বাংলাদেশে, বঙ্গবন্ধুর জন্ম শতবার্ষিকী উদযাপন উপলক্ষে এই যে কার্যক্রম হচ্ছে, এই যে সায়েন্টিফিক ওয়েবিনার হচ্ছে, একটা গ্লোবাল যে ফ্যাকাল্টি আজকে আপনারা নিয়ে এসেছেন, প্রথমেই আমার অন্তরের অন্তঃস্থল থেকে আপনাদের সবাইকে ধন্যবাদ জানাই, এবং আশা করি ভবিষ্যতে এই প্রচেষ্টা আরো বেগবান হবে। আজকে আমরা যে ইম্পর্টেন্ট টপিকসের উপরে আলাপ করব, সেটি হলো অটোইমিউন লিভার ডিজিজেস। আমি আমার এটা শেয়ার করতে চাচ্ছি, স্ক্রিন শেয়ার। আপনারা কি দেখতে পাচ্ছেন?
হ্যাঁ, দেখা যাচ্ছে।
জি দেখতে পাচ্ছি।
So আজকে we are going to talk about autoimmune liver disease. And autoimmune liver disease or immune liver disease, there are three of them we know, and we are clinically we practice. One is autoimmune hepatitis, another is primary biliary cirrhosis, another is primary sclerosing cholangitis. And today, my part is to discuss about autoimmune hepatitis in a very short time. This is a very big area to discuss. Primary biliary cirrhosis and primary sclerosing cholangitis will be discussed by Dr. Ashraf. First, if we think about the clinical characteristic of that, the prevalence of autoimmune hepatitis is the highest among all the immune liver disease, and the whole world about 110 to 200 million. And as you can see, it's predominantly women. 80% of the patients are women. The age of onset is usually 16 to 20, or sometimes in 40. There's two peaks we know. There is a definitive HLA association, DR3 and DR4. And the most important serological test is associated with this disease is anti-nuclear antibody and anti-smooth muscle antibody. And when you look at the biochemical pattern, the primary biochemical pattern is a hepatocellular. So we can see the elevation of AST, ALT, or SGOT and SGPT. Importantly, the histological characteristic, which I'll come later on, is mostly polymorphonuclear and lobular inflammation. And this is the hallmark of autoimmune hepatitis. Now, when we talk about autoimmune hepatitis, we know that it runs in cluster. Obviously, it can happen in isolated group, but mostly run in cluster. And that's why family history is very important. And if you look at the family history, the family has other immune disorder. About 25 or 33% patient themselves has coexistent extrahepatic manifestation of other immune disorder, like alopecia, or autoimmune hemolytic anemia, or autoimmune pancreatitis, celiac disease, immune thrombocytopenia, type 1 diabetes, multiple sclerosis, pernicious anemia, polymyositis, Sjogren's syndrome, SLE, thyroiditis. So always look for other autoimmune condition, and I always make the patient aware about it. I always discuss about the little bit of pathophysiology of the disease when I diagnose those patients. So what is the genetic basis of this disease? There is a genetic foundation. There has to be a genetic foundation, but it required a trigger. And the trigger, we really don't know, but we presume it can be viral, it can be chemical, it can be environmental, it can be certain medication, like minocycline, tetracycline, many other medication we know, flecainide. Now, serological markers of an autoimmune liver disease can be just normal liver enzymes. Sometimes there's absolutely no evidence of liver disease. And at genetic risk, but yet to find the key to unlock the immune disorder. So it is a genetic disease. There is a genetic predisposition. It's an autoimmune disease, but we need to figure out what is the key. And if we know the key, we can solve a lot of problem. And that's what we're doing. The current research, in fact, our center, we're doing research to look at the key and looking for the biological treatment. And one of the participants already asked me a question, is there any biological treatment for that? And I'll come up to you on that. Now, autoimmune disease, autoimmune hepatitis, there's two classifications, type 1 and type 2. And type 1 is the predominant class, where ANA, always there, ASMA or anti-smooth muscle antibody may not be there. And you have to understand, about 20% of the patient is ANA negative. That is important. And type 2, we see anti-LKM and anti-LC1. Those are usually positive. It is very uncommon in where I practice in US or Canada. You can see mostly in the Mediterranean region, French Riviera, more common in young women. It tends to be more severe and rapidly progressive. Shwapnil certainly can give some breakdown of this two different kind of autoimmune hepatitis in Bangladesh, which is more, I'm pretty sure the type 1 is the more prevalent one in Bangladesh. Now, this is important. Autoimmune hepatitis can have no serological marker. No serological marker also sometimes can be suggestive of autoimmune hepatitis in some cases, about 10 to 20% patient of autoimmune hepatitis. How do we identify it? We identify it because they have persistent elevation of liver enzymes. We do liver sonogram. There might be some, fatty infiltrate, echogenic echotexture. We see sometimes when you do elastograph or fibroscan, we see they have elevated liver stiffness or fibrosis. And they go to liver biopsy to define the cause of the underlying liver disorder. And we sometimes thought it might be steatohepatitis prior to liver biopsy. But then when you do liver biopsy, then we see it is consistent with autoimmune hepatitis, not NASH. So especially hepatologists or primary care doctors or specialist internal medicine doctors, it is very important to recognize the pattern, especially the histological pattern. And that's why still we do liver biopsy when you think about autoimmune hepatitis, because not only seronegative cases, also to predict what are the treatment we're going to do or give in future, because the treatment we know has to be some immunomodulator or immunosuppressor, and we have to give it for a longer time. So there's side effects, and we have to think about it. Now, this is important. So what we really look at histology of autoimmune hepatitis, we see dense inflammation. You can see all these inflammatory cells. We see piecemeal necrosis. Look at this area, piecemeal necrosis leading to lobular collapse. We see a lot of lymphocytes surrounding the hepatocytes. This is the hallmark of autoimmune hepatitis. And patient with normal echotexture, but abnormal liver function, sometimes we just see only this, lymphocytes surrounding the hepatocyte, and that can be the very early presentation of autoimmune hepatitis. Now, clinical presentation, there is one which is very aggressive. I just have a patient like that. 37 years old woman who come from Guatemala, and this is the patient I saw. Their AST, ALT run 500 to 1,000. Total bilirubin was 15. My patient was 17. The prodrome can be weeks to months. It leads from arthralgia, myalgia, fatigue, look like more like a viral flu kind of symptoms. And obviously, we did biopsy right after the patient get admitted. We did not see anything significant on the radiological study. The patient has severe portal inflammation, interface hepatitis, significant piecemeal necrosis, significant lobular collapse. And it can, sometimes acute liver failure can happen. And in this patient I'm talking about, the patient does develop acute liver failure. We work in a liver transplant center, and the patient gets liver transplant right away. And these are the patients, you have to make the decision of liver transplant very quickly, the aggressive variety. You can save their life. Now, the indolent, that is the most of the patients you and I see all the time. Their AST/ALT run like 50 to 100. Their total bilirubin mostly normal. Majority is normal, 99%. They have very mild prodrome, very mild symptoms. Also, periportal inflammation is very small, very mild. Fibrosis is variable. Acute liver failure never occur. And how you identify, you just do the serological marker and you identify that. Now, this is very interesting. And you and I, we always see this patient. We call it cryptogenic liver cirrhosis, and which has come from autoimmune hepatitis. An older patient come to me, even a younger patient I've seen in my practice. They're stable. They can come with stable cirrhosis or decompensated cirrhosis, but they have normal liver enzymes. They have no inflammation or liver biopsy. And this is what we call burnout autoimmune hepatitis. You remember when Sheila Sherlock come up with the diagnosis of autoimmune hepatitis, and that article she talked about burnout hepatitis. They do have serological marker of autoimmune disease. And this patient who has normal liver enzymes, burned out autoimmune hepatitis, you don't need to give any treatment, remember. Because you treat the inflammation, and if you give anti-inflammatory or prednisone, there's no potential of improvement. In fact, it will increase the risk. It will increase the risk of infection. Now, the patient who has hepatic decompensation, you just treat them like your other liver cirrhosis patient, and you should consider this patient for liver transplant team and give a liver transplant consultation. Now, if you look at the natural history of the disease, if you have the severe aggressive autoimmune hepatitis, this is a small study of 44 patients, and I would say this is a hallmark study. When you treat this patient without anything, with placebo versus prednisone, this is the first study, and it does show that from the beginning, from the first year, at the end of first year, you see there's a significant survival benefit by giving prednisone, and that's why we give prednisone. Now, the treating the autoimmune hepatitis, you and me who treat the autoimmune hepatitis, you know it is an art, but it has a rule, and that's the rule we have to follow. Autoimmune hepatitis, we treat with prednisone. And how I treat, how most of us treat, so if you look at that, when the AST/ALT is high, very high, we start with 60 milligram of prednisone. After 1 month, we drop it down to 40 milligram. Now, interesting, when patient has moderate to severe autoimmune hepatitis, I always start these patients, or even the patient who I think that I'm going to give prednisone, I start with azathioprine. I do the marker, make sure the patient will not develop toxicity from azathioprine before I start them. I usually start both of them at the same time. And then I keep the azathioprine dose there, I keep tapering the prednisone. After 2 weeks, I bring it down to 40. Then after 2 weeks, I bring it down to 20. I keep it 20 for 6 months. And then I bring it down to 5 milligram, small dose, with azathioprine for a long time. And eventually, after 12 months, I discontinue the prednisone. I keep those patients on azathioprine. This is a very classic pattern we follow, and patients respond very well. If you don't do that, you get into trouble. This is a typical case I would like to present. You are referred a 44-year-old female with persistent elevation of LFTs of 200 to 250 range with normal alk phos, total bili, albumin, INR, platelets. Serology is positive for ANA and ASMA, but negative for hepatitis B, hepatitis C. Liver biopsy demonstrates moderate portal inflammation with moderate interface hepatitis, moderate piecemeal necrosis, and metavir stage 2 portal and septal fibrosis. You initiate the treatment with prednisone 60 milligram and taper this by 20 milligram every 2 weeks to 20 milligram. After 2 months, the liver transaminases are normal. You taper the prednisone to 5 milligram every 2 weeks, and the patient is off prednisone to another 2 months. That's the problem. You see the normal liver function test and you stop that small dose of prednisone. You see the follow-up, the patient stop the treatment, liver function tests are going up. Now, AST and ALT is 120 to 120 and 180 with normal other parameters. What would you recommend at this point? And this is you're going to see, even some patients, internal medicine specialists might do that. And we know the answer is C. We have to restart the prednisone. We have to restart the azathioprine again. And there's a very nice study. And based on the study, I can tell you, when you stop the prednisone too soon, this is what happened. Your liver function tests start going up. So what you do, you don't restart the prednisone alone, or don't restart the prednisone in a small dose, because if you start it with 5 milligram dose without adding the prednisone, your baseline LFTs will keep on going up. That means your liver inflammation will keep on going up. You really need to bump up the dose to 20 milligram. You really need to restart the azathioprine. You really need to keep it for a long time. If you break this treatment, you might need to do it up to 6 months to 12 months in a higher dose, and then slowly taper it to 5 milligram and keep it like that for at least a year or 2, and then discontinue that and just keep the patient on azathioprine. So remember that. Be careful about tapering off prednisone very quickly. So if you do it in a higher dose after 1 year, look how nicely it is coming down. And look how nicely it is continuing like that. So this is very important for us who treat autoimmune hepatitis. Now, there is a good number of cases where there is resistance of treatment we see, And these are the patient. If you see the patient is consistently running the AST and ALT in between 200 to 400, these are the patient we switch to alternative therapy. Don't wait. You need to think right away. And what do you switch to alternative therapy? One is budesonide, another is mycophenolate mofetil, and another is calcineurin inhibitor like cyclosporine and tacrolimus. So, azathioprine, a small number of cases, we do see it is resistant to the azathioprine and prednisone treatment, and this is the way to proceed. How many patients I have? Probably less than 0.5% who I put them on alternative treatment. But it is very important to treat them accordingly. Now, this is a very interesting study I would like to tell you. This talks a lot about the natural history and the treatment of mild to moderate autoimmune hepatitis. Remember, mild to moderate, not severe. And in a mild to moderate, whose LFTs not go above 250, look, if after 2 years, you even stop the prednisone, if you don't treat it at all, the mortality benefit remain the same up to 10 years. And the patient who you treat with prednisone and azathioprine, look, up to 6 years, there's significant mortality benefit, but after 6 to 7 years, it slowly comes down. And after 10 years, it remains the same. So after first 2 years in mild to moderate cases, if the patient survive, if the patient do well, we can think about discontinuing the cases. I have a colleague who has autoimmune hepatitis. He's an internal medicine doctor. I see him all the time. I see his patient all the time. And he does have mild to moderate autoimmune hepatitis. And after 2 years of treatment, he said, hey, I would like to discontinue my azathioprine. What do you think? We discussed a lot about this. I cited this study. I stopped it. So for many years, he's fine. So this is important to think in some point, maybe you can discontinue the immunomodulator. Now, there is a good number of cases where you see a persistent elevation of LFTs. I always tell my patient this is a chronic disease, it goes ups and downs, and it changes the clinical course. 80% of the patient will have a relapse if immune suppression is discontinued. 80% patients, very important, I tell my patient, don't stop your medicine. If most patients need lifelong monitoring and treatment, even the patient get better, I tell them come every 6 months. And fibrosis progression will occur up to 33% despite having normal liver function tests. And I always tell those patients that, listen, it will happen even you look like you're normal. How to decide which patient come off the treatment is a trial and error. You and me, we both know, we all know, it's very unpredictable. And if you see the patient's LFTs are going up, I always re-biopsy them. And you know why I re-biopsy them. So what is the role of the biopsy? First of all, we confirm the diagnosis, serological diagnosis to emphasize what therapy you would like to give, what medication have the potential for the adverse event, because a lot of side effects of all those medicines, prednisone and azathioprine, and we have to start those for a longer time, we have to give them. So we need to make sure that it is autoimmune hepatitis. We assess the response of the treatment, especially the patient who has rowdy course, and you see patients doing well, suddenly LFTs are going up, inflammation is going bad. It was mild to begin with, but after 3 years I've seen it turned to severe disease and required liver transplant. So it is very important to do a liver biopsy in certain point. And sometimes we see that, and Ashraf will talk about primary sclerosing cholangitis and primary biliary cirrhosis, but you can see there is an overlap of all three diseases in a small number of cases. So there's an overlap syndrome. And I will give you a little tip. I know he's going to talk about PVC and PSC, but whenever a patient has a overlap kind of symptom, when it's overlap with PBC, the liver chemistry is like PBC, but the serology is like autoimmune hepatitis. AMA is negative, NA is positive, antibody to the carbonic anhydrase 2 is positive. As long as the histology look like autoimmune hepatitis, this kind of patient you treat like autoimmune hepatitis. You give them a steroid. But certain patients who has liver chemistry is like autoimmune hepatitis, but the serology is like PBC. AMA is positive, NA is negative. and histology consistent with PBC, you have to treat them like PBC. And that's why I'm telling the liver biopsy is very important. When there is a overlap, make sure it's not coming from any medication, make sure it's not some infectious liver disease or from dietary supplementation. I have an autoimmune patient who will start taking protein for bump up his muscle, and he has totally PBC-like treatment, like histological feature. Serology was negative, and we find out he was taking this Chinese protein shake. So we stop it and become pure autoimmune hepatitis. So you have to look at those. So if you see the liver chemistry is like autoimmune hepatitis, but the biopsy look like PBC, you need to treat those patients like PBC. Those are the patients you can think about giving ARSO. So the same way, the PSC, you do liver biopsy. If the liver biopsy look like autoimmune hepatitis, you treat them, though the chemistry look like PSC. The same way, if the liver chemistry is autoimmune hepatitis, but the biopsy look like PSC, you treat them like PSC. So this is what is very important, and this is where I'll stop. We just so this is my, I don't know if I'm able to finish it in time. I was given 20 minutes, but I talked quite a bit about the treatment. Now you can see the role of biological is still, you have immunosuppression, you have immunomodulators, and there is some biological agents we are trying, still on the trial, but it's not approved by FDA yet. But there is one potential biological is coming for very severe cases, has some good results. First of all, you know that the number, the cohort is very small. So unless it's absolute improvement, we don't like to give it. But till now, that biological is not approved by FDA yet. Hopefully, by the end of this year, we are hoping that one biological will come only for the severe disease.
Thank you, Dr. Atiquzzaman, for your brief discussion about autoimmune hepatitis. It will be very helpful to us and also our Phase B student of BSMMU Hepatology Department. Now I request Dr. Ashraf Malek, Associate Medical Director, Transplant Hepatology, New Jersey, USA, for his discussion.
Good morning from USA. Good evening in Bangladesh. First, I'd like to thank Dr. Atiq Bhai. I know him for a long time, for asking me to invite to this session, international scientific session. I also like to thank Dr. Mamun, Professor Mamun. I know him by name. I know a lot of good things. I know he's very famous hepatologist in Bangladesh, so I'd like to thank him. Also to invite, organized by Bangladesh, BSMMU, Hepatology Alumni Association, and Forum for the Study for Liver Disease. The known face is Dr. Alok. He's my batchmate. I know Prabhat. He's from Salumullah Medical College. He was asking, I guess I heard some discussion whether he knows me or not. The reason he probably don't know me because I was not really a big figure in medical college. The only thing I did in medical college was used to involve in the sports. I don't know if you ever watched basketball. We're batch 16. We're a champion all through 5 years. So I'm not sure you have watched basketball at the time. So I used to play a lot. So that's probably I was not a big figure. So that's why he probably didn't recognize me. I know there are a lot of other members. I don't know personally, but of course they're in, expert in Bangladesh medicine and hepatology. So thank you for giving me opportunity to this platform and Planetary Health Academia. I really salute all the member, especially Atiq Bhai and Tasbir Bhai. They're doing a lot in terms of collaborating, sharing the knowledge and everything. So without any further ado, I'll start my talk. I'll try to finish on time. There are two diseases. I don't know how much common primary biliary cholangitis or primary sclerosing cholangitis in Bangladesh. So I just try to focus on mostly clinical oriented talks. Let me share my screen. So I'm not able to move to the next screen. Let's see.
We can see your presentation.
You can, but I'm not able to move to the next screen. Let me see.
You open the whiteboard screen. Please,
Okay.
Please reopen.
Okay. I did click on the whiteboard.
No, not the whiteboard. First, you have to open your presentation behind your Zoom screen.
Okay.
Then click the share screen. Then you can see your presentation.
Okay. Okay.
Yeah, we can see.
All right. So today, during the two diseases, this is my outline of the talk. We'll be talking about natural history of the disease, the diagnosis. I'm sure everybody knows how to diagnose two diseases, clinical manifestation, extrahepatic manifestation, the most common ones, and the disease association, which is the most important ones I'll be talking about, the complication of the two diseases and management. Primary biliary cholangitis, it used to term as cirrhosis, which is kind of a misnomer because not all primary biliary patient will have cirrhosis. Some may have early stage of disease. So this was changed to primary biliary cholangitis. It's a chronic progressive cholestatic autoimmune liver disease. The risk factor, there's some genetic risk factor usually associated with HLA gene, and then environmental, such as prior history of any urinary tract infection, hormonal, especially since this disease is mostly seen in female. As you can see, female to male ratio is about 9 to 10:1. Most patients with primary biliary cholangitis, they are in their 40s or 50s. Median survival, there is a study done, it's an old study in 80s, have shown that about asymptomatic patients, their median survival is 16 years without treatment, and symptomatic patient is about 7.5 years. So this is a progressive disease. Without treatment, it can lead to cirrhosis and liver failure. So who are the patient at high risk of disease progression or greater risk of disease progressions? So if the patient is diagnosed at a young age, usually less than 45 years, male gender, although it's a female predominant disease, if it is diagnosed in a male patient, this is considered a patients with high risk for disease progression. There are certain antibody, which are called PVC specific antibody, GP210, or anti-centromere antibody. associated with high risk for disease progression. And of course, we know if the patient already has developed fibrosis, either stage 2 or more, or they have evidence of hepatic synthetic dysfunction, they have a high risk for disease progression. Okay. So how do we diagnose primary biliary cholangitis? If the patient present with unexplained or persistent elevation of alkaline phosphatase, so for instance, the blood test is done and it shows alkaline phosphatase about 1.5 times of upper limit of normal. I'm not sure what is the cutoff in Bangladesh for alkaline phosphatase. So in USA, the cutoff is, let's say, 150. So if the level is 225 or high, I mean, it's been persistent for 3 to 6 months, then there's no other explanation. The imagings are fine, showing no biliary tract disease. Then you check for antimitochondrial antibody. This is a PBC specific. It's a very highly specific, 90 to 95% patient will have antimitochondrial antibody. If the antimitochondrial antibody is positive and a patient has elevated alkaline phosphatase for 6 months, about more than 1.5 times upper limit normal, we have the diagnosis of primary biliary cholangitis, and then patient can be started on treatment. On the other hand, if the antimitochondrial antibody is negative, if the all the workup are negative, and there's still high suspicion, the next step will be to get PBC specific antibody, which is ANA with a different pattern. So if you do an ANA or antinuclear antibody, they will give you a different pattern of ANA. The one that is very specific for PBC would be SP100 or GP210, if that is positive. And also, patient needs to undergo liver biopsy. Since AMA is so highly specific, if it is negative, we need to confirm by liver biopsy. The hallmark feature of liver biopsy is called fluoride duct lesion. And I'll show you a pathology slide. How does it look like? How about the clinical feature? Some patient can be asymptomatic, can be diagnosed on routine laboratory test. The blood test may show the abnormal cholestatic liver enzymes. Other patient may develop one of those symptoms, and most common one are fatigue, which is mostly seen 50 to 70% of the patient. Some patient may have pruritus. There are some exacerbating factors. So for instance, heat or tight clothing, or pregnancy, or hormones like estrogen can exacerbate pruritus. So those are the things a patient may experience. Some patient may have right upper quadrant pain. Patient may have elevated AST and ALT, but the level of AST and ALT usually don't go high. As Dr. Atiq mentioned, in autoimmune hepatitis, you will see markedly elevated AST or SGOT or SGPT. In PBC patient, usually the levels are less than 5 times of upper limit of normal. So usually it goes below 150 to 200 range. If it is above that, we need to exclude secondary cause of abnormal LFT. The patient may have hyperlipidemia. There are some extrahepatic manifestations. The most common one called Sjogren's syndrome. Usually they present with dry eyes and dry mouth, or keratoconjunctivitis, sicca, or xerostomia, which I'll talk about how to manage those. Thyroid disease, they can have hypothyroid, they can have hyperthyroid. The most common thyroid disorder in PBC patient usually Hashimoto's thyroiditis. They can have systemic sclerosis, also, although very uncommon. The patient can have extrahepatic manifestation of PBC. Crest syndrome is also very, very uncommon in extrahepatic disease. So a patient had a routine blood test done. For some reason, they may have AST, ALT elevation, but alkaline phosphatase, was abnormal, and the tests were done. Everything comes out fine, but eventually they normalize. But for some reason, some patient may have just check for positive mitochondrial antibody, but they don't have any symptom, and they don't have abnormal liver function tests. So what to do with this patient? And there is a nice study done, have shown patient with positive AMA, they may be at the preclinical or subclinical stage of PBC, because 1 out of 6 patients who have positive AMA may develop PBC in 5 years. So this patient needs to be monitored. There is no guideline how often they should be monitored. They can be monitored every 3 to 5 years or so, since 1 out of 6, which is about 16%, may develop PBC over time. This is a pathology slide of one of my patients who has PBC, as you can see, very busy portal tract. In the middle, where the arrow, it's a bile duct. This Freud duct lesion is characterized by dense inflammatory infiltrate around the duct. So you see a lot of lymphocytes, mostly. You can see plasma cells or histocytes, and there will be a damage to the duct. The duct, this is the differentiating point from the PSC, which is another cholestatic autoimmune disease where there is no damage to the duct. So you will see in PBC, along with inflammatory infiltrate in the periductal region, there will be a disruption of the biliary epithelium. The arrow shows there that there is a disruption of the biliary epithelium. So this is the hallmark feature of PBC. As you can also see, there's also portal information, which you can see any patients with any type of chronic liver disease. But the hallmark feature is the Freud duct lesion. Eventually, when the disease progresses further, they may develop ductopenia. There will be loss of duct in the portal tract area. The management, the cornerstone of the primary treatment is ursodeoxycholic acid. It's given at 13 to 15 milligram per kg body weight. It's a choleratic agent. It also has, so it decreases bile acid synthesis. It detoxifies bile acid. At the same time, it also improves. It is also anti-inflammatory, anti-fibrotic. Multiple studies shown that it delays the progression of this disease. It doesn't really regress it or cure the disease. It's really just to delay the progression. So patients who are diagnosed at early stages of the PBC, they will have the most benefit because if it started early, likely their fibrosis will remain stable over many decades. If the patients were diagnosed at late stage, unfortunately, it will only delay, but eventually they will develop cirrhosis and liver failure. It also improves survival. The ursodiol, multiple studies have shown that. Once the patient started on ursodiol, the response has to be assessed after 1 year. And why it is important? Because patients who are poor responder or does not respond very well or non-responder, which can be seen up to 40% of the patient, if the disease continue, eventually they will develop liver failure. So the biochemical response has to be assessed up to 12 months. There are different society have come up with the different parameter or cutoff. What should be the cutoff for defining non-responder or incomplete responder? So there's like a Toronto group, a French group, a Rochester group. More or less everybody kind of has the similar pattern. In a nutshell, if alkaline phosphatase is more than 1.5 times to 2 times of upper limit of normal after 1 year of therapy, this patient is considered inadequate responder or incomplete responder, then second line treatment should be offered. And what are the second line treatment? The most common one, which is the new one, recently approved in 2016. I know this medication is being also prescribed for other liver disease, such as fatty liver, which is called obeticholic acid. So this should be a second line. This is FDA approved second line treatment option, patients who are non-responder to ursodeoxycholic acid. One thing about the obeticholic acid, I want to caution about the patients who have decompensated liver disease, either Child-Pugh B or C. The appropriate dose has to be prescribed because there has been report of death in USA after this medication was approved because patients were given higher dose of obeticholic acid. The second, patient may have pruritus and other symptoms, and they may have abnormal liver function tests, so they should be monitored very closely once obeticholic acid is added. The other options are off-label. One is fibrate, bezafibrate, which is not available in U.S., and then fenofibrate, which is in U.S. Both have shown to improve alkaline phosphatase. Bezafibrate has more data. About 50 to 60% patient can have normalization of alkaline phosphatase after adding bezafibrate. Budesonide is another medication. This is also an off-label. Unfortunately, this is not being used as commonly as fibrates, but studies have shown adding budesonide can be also alternative to other medication, have shown to improve cholestatic liver enzyme, especially alkaline phosphatase. Now, next are the symptom. What are the symptoms the patient who experienced with the PBC and what managements are available? And then I will talk about some extrahepatic manifestation and their management. Fatigue is very common in PBC and a lot of other liver diseases. It is kind of hypothesis that change in serotonin neurotransmission cause fatigue. So there have been some studies done, such as ondansetron and SSRI, such as fluoxetine and modafinil. None have shown to improve fatigue. Recently in liver meeting, there is this presentation of a graded exercise. This is more of like a yoga. So if the patients were, given home-based exercise, have shown significant improvement of their fatigue. So this is something the patient can be advised to do at home, some yoga that can help with their fatigue. Pruritus is very common, not only in PBC, any cholestatic liver disease, and even patient with advanced liver disease. The first option would be anion exchange resin, which is cholestyramine. One thing you have to keep in mind with the cholestyramine is about it can impair absorption with other drugs. So that can be prescribed. Rifampicin or rifampin, 150 milligram daily can start with and then can go up to 300 milligram twice a day. One thing about rifampicin, it is hepatotoxic, so liver function test has to be monitored. Most commonly seen is hyperbilirubinemia after starting the therapy. So once the patient starts on medication, the liver function test, especially bilirubin, needs to be checked in about 2 to 4 weeks and then every 3 months afterwards. Naltrexone has been studied, have shown to improve pruritus, and the rationale is when PBC patients that have increased endogenous opiates, so naltrexone is an opiate antagonist, have shown to improve significant pruritus. Sertraline is a SSRI antidepressant, also shown a couple of studies to improve pruritus. Antihistamine like diphenhydramine can be used. There are a few like routine measure can be advised to the patient. This really helps since we know like tight clothing and heat can exacerbate pruritus. So patients should be advised loose clothing, skin moisturizers such as wraps or cooling or moist wraps. There's some experimental therapy with phototherapy, albumin dialysis, or nasobiliary drainage, which is also indicated in patients with cholangitis, but these are all experimental. And refractory pruritus, plasmapheresis can be offered in USA. Liver transplantation is one of the indications for refractory pruritus. Sitka syndrome, which is dry eyes, artificial tear, patient can use. Either they can be referred to ophthalmologists or some cholinergic eye drops such as pilocarpine, cevimeline can be prescribed. If they're really refractory to all this medication, ophthalmologists can prescribe cyclosporin or other ophthalmic solution. Sitka syndrome, dry mouth, which is xerostomia. They are high risk because of the dry mouth for dental infection, so they should check with the regular dental appointment. This is also applied to all liver patient, advanced liver disease, especially with alcohol-associated liver disease. They're high risk for dental infections. They should see dentists on a regular basis. Some saliva substitutes such as sugar-free gum, candy, moisturizing mouthwash can be used. Again, cholinergic mouthwash such as pilocarpine can be prescribed in dry mouth. Osteopenia, osteoporosis is very common, not only in cholestatic liver disease, as you all know, it's also very common in any advanced liver disease. Cirrhosis, very high risk for osteoporosis. Patients should undergo bone mineral density every 2 years. All patients should receive calcium and vitamin supplement. If the patient has, osteoporosis, oral bisphosphonate should be considered as long as there is no varices. As we know, bisphosphonate oral can cause esophagitis that can cause increased risk of bleeding with the varices. Patients should be educated. Some PBC patient can become pregnant. And again, during pregnancy, as we know, because of increased hormone, it can exacerbate pruritus. So they should be advised about all those routine measures like loose clothing and all that. All cholestatic liver disease are high for different fat-soluble vitamin deficiency. D is more common. A is we see more in advanced case, same thing with the E. So it should be measured on a routine basis and supplement can be used. For instance, for A, you can prescribe 25,000 once a week or twice a week. One thing to keep in mind with the vitamin A would be because vitamin A is hepatotoxic, it can cause hepatofibrosis. So once a patient was prescribed vitamin A, their level should be monitored. Vitamin E can be prescribed at 400 units a day. Hyperlipidemia can be observed in PBC as an extrahepatic manifestation. Statin or fibrates can be used. Fibrate could be a reasonable choice, as we know fibrates can also improve liver chemistry. So that could be a good choice if in PBC patient. There's a genetic inheritance. So first degree relative should be counseled about getting checked, especially patient's sister. If the male patient or patient's brother, they're the highest risk. They can start checking at age 30 with the alkaline phosphatase. If it is abnormal, then check mitochondrial antibody. If it is normal, repeat one can be checked at 5 years. PSC is another cholestatic liver disease. It's a chronic, and again, there's autoimmune, mainly autoimmune component. This is characterized by inflammation and fibrosis of both intra and extrahepatic duct. Now, some patients may not have both intra or extrahepatic duct. Some patients may have intrahepatic duct involvement, which is seen about 25%. Extrahepatic duct involvement is much less common, but also can be seen less than 5% of the patient. This liver disease is also progressive, eventually lead to hepatic cirrhosis and liver failure. We all know very strong association with inflammatory bowel disease or IBD. Patient with PSC, there's an 80% patient will have IBD. Conversely, if the patient has IBD, only 5 to 10% will have PSC. Most common IBD is ulcerative colitis. About 75 to 80% patient will have ulcerative colitis among the IBD. And about 10 to 15% have Crohn's disease. Now, if the patient has Crohn's disease, usually there should be a colon involvement. Patient with Crohn's disease without colon involvement usually don't have PSC. It's a male-predominant disease, usually at a young age, around 30. Mostly it's seen in male. And again, pathogenesis is a combination of genetic, immunologic, or environmental factors such as smoking can predispose to PSC. There is a study done in Netherlands about 4 centers. In the past, there was a study showed that median survival was 10 to 15 years. But the Netherlands study have kind of gave us some hope. It showed that median survival of this patient, there are about 590 patients they followed for many years and have shown that median survival is 21.3 years. Diagnosis, most patient PSC can be asymptomatic because, or they may have other features. So asymptomatic patients, they may have for several years and before they become symptomatic. Once they have symptoms, they may have fatigue, pruritus, all the cholestatic symptoms they can experience, right? Upper quadrant pain and weight loss. The laboratory test will show abnormal cholestatic liver enzymes. Same thing, high alkaline phosphatase. They may have normal AST or SGOT or SGPT, but they may have abnormal AST or ALT. But usually, the level does not go beyond 2 to 3 times our upper limit of normal. One thing I want to mention that patients with PSC may have normal liver enzyme. They may have found incidentally on the imaging like ultrasound, or for some reason have MRI done, may show the typical pattern of PSC on the MRI. So it's something can be seen in PSC patient. Antibodies has limited value in PSC, but the most common autoantibody seen is P-ANCA, ANA, SMA, and RA antibody can be elevated, but these are not very specific for PSC. Elevated IgG can be seen in 60% of the patient. If the IgG is elevated, one thing we need to check is IgG4, which I'll talk about why it's important. But IgG elevation is not as high as we see in autoimmune hepatitis. The first diagnostic test in diagnosing PSC would be MRCP. And I'll show you some picture of MRCP and ERCP patients with PSC. What we see is in MRCP or ERCP would be multifocal, short stricture with normal or slightly dilated segments. It looked like a beaded pattern. So it's a diffuse disease. It involves multiple ducts and will stricture and dilatation giving the beaded appearance. Advanced stage, it will be pruning of bile duct, which means the bile duct eventually, at the distal bile duct, it will disappear eventually. So it's called pruning of the bile duct. There's another variety called small duct PSC, is less than 10% of the patient. The definition of small duct PSC would be patient with normal cholestatic liver enzyme, no other cholestatic liver disease, and normal cholangiography. So MRCP and ERCP will be normal, and if there's still high suspicion, the biopsy will be done and it will show typical feature of small duct PSC. So the important thing about the small duct PSC, it's a much better prognosis than the large duct PSC or conventional PSC. It has much less risk for other cancer, such as colorectal cancer, and some patients with small duct PSC over time can develop large duct PSC. The next one is secondary sclerosing cholangitis. It is important, I think, in Bangladesh perspective. You might see a lot of, some of these are very common. These patients may have secondary sclerosing cholangitis. Before diagnosing PSC, all patients to exclude for secondary sclerosing cholangitis, such as cholelithiasis, which can be seen in MRCP or ERCP, cholangiocarcinoma, this is more associated with PSC. IgG for associated cholangitis, it's an autoimmune pancreatitis, it's a systemic disease, mostly seen in elderly patient. So as I was mentioning, if the IgG is elevated, the IgG4, which is a subtype of IgG, should be measured. If it is very high and the patient has pancreatitis, and usually an elderly patient, this is a IgG4 associated cholangitis. The other terminology of this called autoimmune cholangitis. Ischemic cholangitis is seen in a critically ill patient in ICU. The patient is in shock. They may develop cholangitis. As we know, biliary is supplied by the hepatic artery. So when their patients are in shock, they may develop ischemic cholangitis. HIV cholangiopathy, recurrent pancreatitis, surgical biliary trauma can occur also during, like, for instance, cholecystectomy or other biliary surgeries. Interarterial biliopathy is seen patients undergoing TACE, which is transarterial chemoembolization for treatment of liver cancer. We know that the bile duct, if you look at the bile duct, the CBD is usually supplied by the branches from the inferior retroduodenal artery. But if you look at the intrahepatic ducts, usually supplied by the branches from the right and left hepatic duct. So if there is a TACE done, sometimes it can affect some of the branches and can cause secondary sclerosing cholangitis from the TACE. And the recurrent pyogenic cholangitis also eventually can lead to fibrosis and eventually secondary sclerosing cholangitis. This is a cholangiography finding, very typical. On the left side, it's an MRCP, as you can see, beaded pattern, dilatation, and beaded pattern of the bile duct. ERCP, this is much better picture than, as you can see, beaded pattern of the intra and extrahepatic bile duct. One thing I want to mention about the MRCP and ERCP, all the MRCP is a very good diagnostic test. Some patients with early PSC, MRCP can be normal. So if there is still high index of suspicion of PSC, if the MRCP is normal, ERCP can be done because early stage of PSC may not be seen on MRCP. Dominant stricture, one of the very important complication because it does affect survival. Patient with PSC, it's a different survival pattern. Patient with dominant or without dominant stricture. The definition is if the stenosis is less than 1.5 millimeter in CBD or less than 1 millimeter in common hepatic duct within 2 centimeter bifurcation. This is called dominant stricture. It's in about 50% of the patient. Any patient with dominant stricture, we need to exclude cholangiocarcinoma since 25% may be malignant. The patient may present, so a typical case, if the patient present with worsening cholestatic liver enzyme, for instance, they have increased bilirubin or markedly high alkaline phosphatase from the baseline, or they have a worsening pruritus, or importantly, if they come with bacterial cholangitis, patients should go further testing to exclude secondary malignancy. This is a study done on the right side of the slide. Patients are followed for 20 years. As you can see, patient with dominant stricture, they're 18-year survival and 25% in comparison to patient without dominant stricture, which is about 73%. How do we manage? Patient, again, dominant stricture should undergo ERCP. We need to exclude malignancy with the dominant stricture. So they can undergo balloon dilatation and, of course, brush cytology or biopsy. I'm not sure whether FISH study is available in Bangladesh. This is a very special technique where, because cytology is only 40% sensitive, meaning that if it's negative, and if you have a still high suspicion, patients should go further monitoring. That's why FISH study may increase sensitivity, meaning that if it is negative, then you can confidently say this is probably negative. So FISH study, what they see is this is duplication of 2 or more chromosomes in the biliary epithelial cells. If it is more than 5 cells that's seen, that's called FISH polysomy in FISH study. So that actually increased sensitivity. This is highly specific. So if it's saying that patient do have high-grade dysplasia or cholangiocarcinoma, it is, you can say confidently the patient does have the cholangiocarcinoma or high-grade dysplasia. But if it is negative without FISH study, this is only 40% sensitive. So all patients with ERCP should undergo and get brush cytology. Patients should receive antibiotic prophylaxis. Again, the contrast can initiate cholangitis. So all patients, I'm sure they do receive that. Routine stenting after dilatation of dominant stricture is not required. There's a nice study done about addressing whether stenting should be performed in all patients with ERCP and dominant stricture. And the study have shown that as long as there is no severe stricture, dilatation probably would be enough, and there is recurrence-free survival is similar. And with the stenting, there's a little bit higher risk of complications. So as long as there is no severe stricture, only dilatation will be enough, and the patient should have a biopsy done. If the ERCP is unsuccessful, for instance, for some reason it's so severe stricture, sometimes it can happen. I think Mamun, I know he does a lot of ERCP. He'll be able to tell us a little bit more about it. Then PTC can be performed with or without stenting. Surgical treatment is rarely done, especially the cirrhotic patient, but that's something in refractory case can be considered. A little bit about PSC, IBD, and gallbladder disease. This is very, kind of go hand to hand, all these 3 diseases, because of risk of cancer in 3 diseases. In majority of the patient who have IBD and PSC, IBD usually precedes PSC. Sometimes it can occur at the same time, or sometimes IBD can occur after the diagnosis of PSC. And again, like I said, Crohn's disease has to be confined to the small bowel. Crohn's disease, which are confined only to the small bowel, usually not necessarily PSC. Mostly they have pancolitis, mostly on the right side. There's a rectal sparing and backwash ileitis. PSC and IBD patient, they usually IBD is a mild or asymptomatic course. So most patients either need a little bit of treatment or may not need treatment. They have a high risk for colorectal neoplasia, and I'll show you some data about the risk difference. There's increased risk of pouchitis in patients who underwent proctocolectomy and ileal pouch anal anastomosis. So any patient, the reason since there is a very strong association with PSC and IBD, once the patient is diagnosed with PSC, should undergo colonoscopy and random biopsy, make sure patient does not have IBD. Once they have diagnosed with IBD because of high risk for colorectal cancer, surveillance colonoscopy should be done every 1 to 2 years. This is very important because of very high risk of colon cancer. And I'll show you some data. There's a significant high risk of colon cancer in IBD patient with PSC in comparison to without PSC. Patients with PSC also at high risk for cholangiocarcinoma. So ultrasound can be done or MRI or MRCP every 6 to 12 months. One approach can be ultrasound can be done every 6 months. Or if the MRI is done, then it could be done every 12 months along with CA19-9. PSC patients are also at risk for gallbladder mass lesion and gallbladder cancer. So annual ultrasound should be done. The prevalence is about 3 to 4%. If any mass or any polyp is seen in the gallbladder during screening, the best thing would be to take out the gallbladder. Cholecystectomy should be done regardless of the size of the mass, which is different from usually patients who don't have PSC. You can monitor them very small polyp. But patients with PSC, any size of the gallbladder mass or polyp, patients should undergo cholecystectomy. This is a study have shown the difference of in high risk of cholangiocarcinoma. There are two bars there. The top one is a solid bar. The risk of cholangiocarcinoma, lifetime risk about 15 to 20%. Annual rate is 0.5 to 1.5%. So all patients should undergo screening, either ultrasound or MRI every 6 to 12 months. The bottom bar showed, the gray bar is the risk of high-grade dysplasia or colorectal cancer. As you can see, very high risk of. And there is a second study I'll show you next slide, the difference in PSC or without PSC. Who are the patient at risk for increase of cholangiocarcinoma with PSC? The patient with the older age of diagnosis, smoking, alcohol, duration of IBD, presence of colorectal cancer or dysplasia, patient who had a proctocolectomy or variceal bleeding, all increases the risk further. This is a difference in risk of colorectal cancer, patient with PSC and without PSC. The top bar, the solid black bar showed PSC IBD patient, 10-fold increase. It's much, much higher risk. Again, patient with IBD and PSC should undergo colonoscopy every 1 to 2 years. And then not only they are high risk for colorectal cancer, they develop at much younger age. The study shows that the average age patient who had colorectal cancer with PSC and IBD is 39 years versus 59 years. This is a kind of algorithm how to monitor or kind of screen patient for suspicion of cholangiocarcinoma. You can do MRI, CA19-9, ERCP. So depending first, I would start with the MRI and CA19-9. If the MRI shows there is a mass or vascular encasement, usually it's an intrahepatic cholangio, biopsy should be done, especially in the setting of high CA19-9. If the MRI is normal and your CA19-9 is high, then our patient present with pruritus or worsening bilirubin should undergo ERCP brushing cytology, and especially if there's a malignant appearing stricture, most cases biopsy may show either high-grade dysplasia or cholangiocarcinoma. If there is no concern, MRI imaging is fine, low CA19-9, negative cytology, you can observe them, or if there's still a concern for cholangiocarcinoma, you can repeat the study in 3 months or so. The management, unfortunately, there's no currently approved treatment for PSC. UDCA has been prescribed in some centers, several places. In USA, 50% patients are on ursodiol. Internationally, about 57%. You can consider if the patient has history of colorectal neoplasia or history of colorectal cancer. There is some soft data about chemo prevention effect, but this is something should be assessed in 6 months. If there is no improvement, especially if the alcohol phosphate does not go down below 40%, above 40%, then you should consider stopping the therapy. If the patient does improve to medication, their alcohol phosphatase does go down significantly, you can continue them because it can improve liver chemistry, but there is no demonstrable survival benefit. UDCA at a dose of more than 28 milligram per kg should not be used. There are a study done and actually it was prematurely stopped because of higher mortality with a higher dose of UDCA. Management of pruritus and vitamin deficiency and osteoporosis I had alluded in my previous slide in PBC patient. So take home message, response to ursodiol or ursodeoxycholic acid should be assessed in patient after 1 year. If they are not non-responder or incomplete responder, second line treatment such as obeticholic acid or fibrate can be used. MRCP should be preferred method of diagnosis for PSC, but ERCP if there's high index of suspicion or for some reason MRCP is normal and our patient needs some intervention for instance, cholangitis, then ERCP should be performed. Survey. Highs for cholangiocarcinoma, gallbladder cancer, and colorectal cancer. Very important. They should be monitored, especially colorectal cancer every 1 to 2 years. Cholangiocarcinoma every 6 to 12 months. Gallbladder cancer, ultrasound can be done every 1 year. Workup for suspicious stricture with ERCP with brush cytology should be done, patient with dominant stricture. With that, I'll finish my talk. Thank you, and again, thank you for inviting me, allowing me to participate in this important session. if somebody has any question.
Thank you, Dr. Ashraf Malek, for your elaborate discussion about two rare diseases, PSC and PBC. Now the question and answer session. I request Dr. Shunan bin Islam to tell about the question session.
The question is from Taslima Akhtar. Regarding the USA OD UDCA in PBC, can it reduce the risk of development of esophageal varices? Dr. Ashraf Malek, please unmute yourself.
Okay. Yes, that's a very good question. Actually, it does reduce the risk of esophageal varices. There is a nice study done, have shown not only it delays the histologic progression of the disease, it does reduce the risk of esophageal varices. Yes.
Thank you. The next question is also from Taslima Akhtar. Is there any diagnostic or prognostic significance of raised vitamin B12 in a patient of CLD?
In patient with, I'm sorry, is it for me or?
I think it's for you. Is there any diagnostic or prognostic significance of raised vitamin B12 in a patient of CLD?
Oh, so chronic liver disease, in general, chronic liver disease? Okay. I know there is some, like a small data, these are like a very anecdotal report about some association with vitamin B12 and chronic liver disease, but I don't think so there is any association with vitamin B12 and chronic liver disease.
Thank you. There are no other questions.
Thank you, Dr. Shunan bin Islam. Now the panel discussion. Now I request Dr. Prabhat Kumar Poddar, Associate Professor, Hepatology Department, Shah Salimullah Medical College, for tell about his discussion.
Thank you, Moderator Dr. Abdul Rahim, Associate Professor, North Medical College, and I congratulate and thank both the speaker, Dr. M Atiquzzaman and Dr. Ashraf Malek, for their nice and brilliant presentation. And thank you all. And now I also thank to organizer Forum for the Study of the Liver Disease of Bangladesh and Bangabandhu Sheikh Mujib Medical University Hepatology Alumni Association and Planetary Health Academia. And today's discussion about autoimmune hepatitis and primary biliary cholangitis and biliary and primary sclerosing cholangitis, but the speakers and deliver well and deliver their speech nicely, and I think our participants know a lot from their speech. So I thank to them and also congratulate the organizer, and thank you all. Good night.
Thank you, Dr. Prabhat. Now I request Dr. Arun Jyoti Tarabdar, Associate Professor, Mamun Medical College, for his discussion.
Thank you, organizer, moderator, and all the participants. Firstly, we are very much amazed to see our big brother Atiq Bhai, our CMCM, and another friend, Ashraf Malek. He is also a friend of Dr. Olafraha is very close to me. Congratulations both of them to speak nicely both rare diseases. Though autoimmune disease is frustrated disease, because those diseases have relapse and remission, they are always frustrated. And not only autoimmune liver disease, all types of autoimmune disease are frustrating disease, because relapse and remission is common. Though we faces these disease as less, so our clinical experience is less. So these two speakers emphasize that things very nicely. So again, we congratulate both the speakers, and we are very much amazed to see our big brother and our friends, and also organizer on the occasion of our great leader Bangabandhu Sheikh Mujib incoming day. Thank you very much, and thanks everyone.
Thank you, Dr. Arunda. Now I request Dr. Alok Kumar Raha, Associate Professor and Head of the Department, Chittagong Medical College, for his discussion.
Thank you. Hello. Am I audible?
Yes, you are audible.
Thanks Professor Mamun, Shwapnil, and thanks Professor Dr. Abdul. I must thank Dr. Atiquzzaman and my friend Dr. Ashraf Malek for their nice and brilliant presentation. We have much benefited from their discussions. Once upon a time in our country, hepatitis was underdiagnosed. But due to improvement of lab facilities, we can now diagnose autoimmune hepatitis. One thing is surprising me that in our country, especially tribal women are more suffering from autoimmune hepatitis. I have diagnosed at least 15 to 20 autoimmune hepatitis patients in tribal women, and their presence with features of or aggressive features of autoimmune hepatitis. Sometimes we misdiagnose them as alcoholic hepatitis, but I found that after giving treatment, they have improved. But I have some questions to Professor Atiquzzaman. In this discussion, he said that negative serology, how can diagnose? He told me he said that we can diagnose with liver biopsy. But is there any special features in liver biopsy findings that will differentiate from other activities of hepatitis or other liver diseases? But there is in the biopsy there is the features in autoimmune hepatitis and other etiology feature is same. So how can we diagnose autoimmune hepatitis with negative serology? One question was I have one question to him. Stopping rule of autoimmune hepatitis, stopping rule of drug therapy in autoimmune hepatitis. In second speaker, Dr. Malek, the BC, but BC and BC are undiagnosed or rarely seen in our country. I've seen two positive BC in our country, but sometimes in our country, some young women, mostly I've seen young women, they have diagnosed BSMMU stricture, with Biliary stricture they present. Is there any association or we should work up for them as or not? So thank you very much. Thank you.
Thank you, Dr. Alok Kumar Raha. Thank you, Dr. Alok Kumar Raha. Now I request Dr. Ejazul Haq, Vice Principal, Kumila Medical College and Head of the Department, Hepatology, Kumila Medical College, for his valuable opinion.
Thank you, Dr. M Rahim and Dr. Mamun Mahtab, specially arranging this today's webinar on the occasion of Bangabandhu's homecoming day. And I like to pay my humble honor to the father of the nation. And thanks to the two speakers, Dr. Atiq Bhai and Dr. Ashraf. Atiq Bhai, after a long time, I am in contact with him. He was very popular figure in our campus in Chittagong Medical College. And he has nicely presented this on autoimmune hepatitis. Actually, autoimmune liver disease, probably it's not very common in Bangladesh. And I am confused whether I have been seen any patient of primary biliary cirrhosis or primary sclerosing cholangitis. But I have, at present, I have one patient in my follow-up, one young girl, 13 years young girl. She is autoimmune hepatitis type 2. Anti-liver kidney microsomal enzyme positive patient. After giving the steroid prednisolone, she is fine now. My question to Dr. Ashraf: how often you get primary biliary cirrhosis or sclerosing cholangitis in USA? Actually, it is rare in our country.
And PBC is also not very common in USA. It's mostly we see patients who are like European descent, like patients from UK or Germany. So I have total, I think, probably about 50 patients in my whole practice with primary biliary cholangitis. So I know in Asian country, one place I think probably a little bit common of PBC would be in Japan. So because there are some patients are from Japan, study from Japan. But usually it's a mostly Caucasian, like white. It's called like a rich patient disease because mostly patients are like, female in their 40s and 50s. They're like, they are not like usual, patients we see hepatitis C. They're like, drug use or all that. So it's mostly female patient we see. I have several female patients, but it's not very common either, even in USA. But if you go to Europe, UK, it's more common. There are a lot more studies from Europe, Netherlands or Germany. PBC are more common.
Thank you very much. One question for Atiq bhai. What is the drug you commonly use in treating autoimmune hepatitis? Is it prednisolone alone or with azathioprine? Which one you prefer?
Thank you. Very good question. There is a significant side effect of prednisolone, and azathioprine also has some side effects, but the prednisone has significant side effect. And this is a chronic disease, and we have to treat them for a long time. And sometimes when they're stable, they're good, but when it come back, we might need to increase the dose as well or reintroduce something. In United States, I have quite a bit of autoimmune hepatitis patient. Though I'm a gastroenterologist, but I have passion for hepatology, and that's why from the fellowship I pick up hepatology quite a bit. But I have to tell you that every single patient I diagnose autoimmune hepatitis, even they're mild to moderate, I put them prednisone and azathioprine together, unless there is some contraindication to give azathioprine. And I think that's the right thing to do, because you'll see in some point this patient is going to recur. So as I shown you from the study from Europe, that I start with a higher dose, I taper it slowly. Sometimes it takes a year or 18 months to taper it down, but then continue with the azathioprine. Now, azathioprine does have side effects. It can cause pancreatitis, and there's some genetic pathway where you have high risk of bone marrow suppression, also hepatotoxicity itself. So I follow them very closely with the metabolite of 6-MP, and rarely in my current practice, I probably have about 5 or 6 patients that I have to change their azathioprine to something else or had to put them on budesonide for a longer time. I'm pretty sure Ashraf, who worked directly as a transplant hepatologist and whose primary focus is hepatology, he has seen more. So that's for your question. And Dr. Alok also asked a very important question, that the seronegative autoimmune hepatitis, you're doing liver biopsy, and if the lymphocyte aggregates are collapsing of the hepatocyte triad, does it the definitive marker? It is, but there is a small number of patients you may not see that, especially the burnt out cases. But nowadays, our pathologists also become very smart. So there is a lymphocytic marker. So there is certain marker. So they stain those marker with a special antibody, and that light up. Those are fluorescent marker, and they use it for autoimmune hepatitis. There's a separate marker for PSC and PBC. Our histopathologist who does autoimmune histopathology or PSC or PBC, they're only hepatohistologists. They only do liver. And I think that is one area I will talk to Professor Mahtab in future when there will be a teaching session come in. We might do a combined session about that. How can we develop hepatohistopathologist who has more focus, and we do have a very good hepatohistopathologist. It's good for us, to tell you the truth, whenever we have a case with autoimmune hepatitis, PBC or PSC, would like to see the slide by ourselves. Still, we do that. We learn during our fellowship. I'm pretty sure Ashraf is very critical about looking at the histopathology himself, and we are very integrated with the care with them, both the radiology as well as pathology. Still we do that. We still have pathology around. So in future we can introduce case-based approach, bring a pathologist, and talk about that. Thank you.
Yeah,
Thank you very much.
I just gonna kind of address a couple of things you mentioned. You're absolutely right. Pathology is so important, especially in hepatology. Not only our hepatology, general hepatology, but transplant hepatology. Every patient with liver transplant do have liver biopsy, but that's a separate issue. But yes, hepatohistopathology is a very important field for all the hepatologists because we do see a lot of kind of overlap cases that you nicely described. As far as the management, as you mentioned, I totally agree. The patient should be started on both at the same time, and most patients has to be on indefinite period. And after 2 years, they should be kind of assessed if they are in remission. So remission is one of the most important one. But yeah, I think it'll be a great idea to have a hepatopathology session collaboration from somebody over here. We can invite somebody, and I think Shwapnil may be able to give more light about the hepatic pathologists in Bangladesh. I have a very important question for Shwapnil later on, and I really like to hear from him later on about stem cell therapy. I know you've been doing it, so I'd like to hear from you more. I'll be very interested to hear from you. But I'll leave it up to Professor Dr. Rahim. I think there are more panelists who would like to view their opinion.
Thank you very much. Thanks to the two speakers for their excellent talk, and thank to the organizer.
Thank you, Dr. Izazul Haq. Now, finally, I request our mentor, Professor Mamun Mahtab Shwapnil, Chairman, Hepatology Department, Bangabandhu Sheikh Mujib Medical University, President, Forum for the Study of the Liver, Bangladesh, and President, Hepatology Alumni Association, Bangabandhu Sheikh Mujib Medical University, to deliver his speech and ended to this webinar.
Thank you very much, Dr. Rahim. It was indeed a pleasure actually listening to you. This is possibly the 26th or 27th webinar we have arranged during this COVID pandemic, but this is the first time that we have two NRBs as speakers, and it actually makes us very proud that we can share our views with our colleagues, with our classmates. The main idea of organizing webinars with you was that when Dr. Atiq proposed to me is that we actually wanted to take this relationship beyond webinars. Webinars are organized regularly, speakers come speak, and we enrich ourselves, but that ends there. So this is the intention that we take it forward, and surely this is one good area where we can collaborate, because the hepatology curriculum in Bangladesh is unique, but there are areas to improve. For example, many of us that you see here are interventional hepatologists. In this country, hepatologists do ERCPs, and some of them will be doing liver biopsies, some of them will be doing transarterial chemembolization, others will be doing radiofrequency ablation, things like that. But it is true that we are not looking into our slides ourselves, and that makes our practice very difficult at times. At least I face this problem every day when I have to depend on one histopathologist who will say or give a diagnosis and make all the confusion and making the scenario very difficult for us. So I am sure we'll talk. We will take this discussion forward, and I think, as we have said, that we can surely have these type of sessions where we can involve our residents also. Instead of going on like this big way, we can make it a very academic session for the hepatology residents too. So that will be very nice. And we were discussing when Atiq proposed and we discussed this collaboration. We were very enthusiastic that we will make this a monthly event, and if you are interested, we can go forward with that. So I will not take much time. It is almost 11:30 in Bangladesh. So before I have to say good morning to finish the session, I better end here saying good night. But it was indeed a pleasure. Very thanks a lot to Dr. Atiq Bhai and Dr. Ashraf, who happens to be my batchmate from a different medical college though. We'll see each other many more times, I'm sure. And surely we can have a different exchange of opinions and like this. And to conclude, I would like to thank the panelists for being here tonight from their very busy schedule. They're all very big names in their respective areas, in their respective cities. We are grateful that they made time to join here. We are grateful to the audience who are here today. And not last but not least, thanks to Raj TV for being with us and taking this event to their 500,000+ followers. Thanks a lot and a very good night to you all. Thank you very much.